Again, I am Andy Weber, CEO of the Maine Health Management Coalition, and I'm so thrilled to be moderating this panel session. The session is entitled The Future of Healthcare Delivery in Maine, a Leadership Conversation. And boy, do we have an all-star cast of leaders here in the Maine for this conversation. And what a perfect tee-up, too, by Ron Sims, who I think really inspired us as a state to be an innovator, to be a leader, to sort of set the path in advancing the triple aim in the state of Maine, and to be an example for the rest of the country to follow. And it's with that high standard that we have this conversation today. So let me introduce first our distinguished panel. To my immediate left, we have Commissioner Mary Mayhew with the Department of Health and Human Services in the great state of Maine. Mary, welcome. Yeah. Wendy Wolf, to my right, CEO of MHMC, the Maine Health Access Foundation, that is doing fabulous work in Maine and has a special mission around protection of more vulnerable populations in the state of Maine. To my far right, Bill Caron, who needs no introduction, CEO of the Maine Health System, one of the leading integrated systems in Maine. To Mary's left is Dan Corcoran, CEO of Maine Anthem, the leading healthcare plan in the state of Maine in terms of covered lives, I do believe, Dan, is that correct? And last but not least, Wayne Gregerson, who's Senior Manager of Compensation and Benefits at Jackson Labs down east, and one of the leading private sector employers that has been an innovator in managing population workforce health, and also an innovator as a purchaser of healthcare in driving healthcare improvement and transformation. So again, I want to thank everyone for being here. This is going to be, again, as the title suggests, a conversation. I've asked the panelists not to prepare their own comments, and we're simply going to throw out questions and hopefully get a conversation going. The ground rules are that we are going to have a respectful debate on the issues. All the panelists have said they will be pithy and to the point, but brilliant in their comments. And so we will hold them. We will hold them to that standard. And we will also have an opportunity to engage the audience, too. We very much want you to be part of the conversation and have this great opportunity with these great leaders in Maine to be able to pose questions and challenges to them. So I want to start the conversation with the aspirational goal of the triple aim, the challenge of how do we get to better healthcare status in the state of Maine, how do we get to high quality healthcare and greater patient care experience, and yes, how do we deal with healthcare costs and bringing down per capita health expenditures. And if Ron Sims is in the room, we are leaders in some of those areas, but I think have a journey to go in some of the others. I think in terms of healthcare, the commitment and the culture of quality improvement in Maine has led to a situation where if you look at any of the statistics on quality of healthcare, Maine is typically in the top 1 or 2 or 3, 4 states. So sort of, I think we can check off the box in terms of healthcare quality, not that we don't have improvements to make there. In terms of healthcare status, we rank last I looked 19th in the country in terms of population health status, so we're sort of in the middle of healthcare rankings in terms of other states. And in terms of per capita, across the board per capita healthcare expenditures, we're actually a very high-cost state, again, relative to other states. So the challenge is clearly defined, and we're going to talk about strategies and steps to make progression and to accelerate the pace of progress against the triple aim. And I sort of want to start there with actually the vision statement of our coalition as a multi-stakeholder collaborative. And the vision, an aspirational one, as all vision statements should be, is that the state of Maine leads the country in population health status, patient care experience, and low per capita healthcare expenditures, contributing to a favorable business climate for economic growth and job development. One of the reasons, healthcare is not in a vacuum. One of the reasons we need to advance the triple aim is to actually create a business climate so we can attract new business to the state. And boy, would that help in terms of, again, advancing the triple aim and spreading the cost across a larger denominator, particularly in the private sector. Remember, in Maine, we are an elderly state, and again, compared to other states, a relatively poor state. And I would also make an argument at the very beginning, as my public health friends tell me, that one of the biggest contributors to health status is socioeconomic issues, better education, higher income. If we can grow the business community, I think that will help the triple aim. So I want to start with sort of that aspirational goal and just go quickly down the line, starting with Mary on my left, whether or not that's a realistic goal for us to be a leader in the country in terms of advancing the triple aim, but also ask, what makes you optimistic that Maine is in a position to be a leader? And perhaps, too, what makes you pessimistic? Or what are the big obstacles that we need to overcome to reach this very aspirational goal? And I'll ask all the panelists as a start to say just a little warm-up on this issue. So, and let me also mention, finally, let me also mention that Mary's leadership and the state of Maine's leadership in organizing the state innovation model, the SIM grant, that brought together stakeholders for the explicit purpose of advancing the triple aim, and makes us a leader in the state, only one of 6 states that got an initial grant. So I think that vision of the triple aim was very much part of this administration's leadership aspiration. So with that, Mary, your thoughts?
Andy, thank you. So glad to be first. I appreciate it. In terms of the aspirational goals, those are obviously critically important, but with any set of goals, aspirational or otherwise, it's important that we have realistic objectives and measures around which we are holding ourselves accountable. And so when we look at the respective efforts that we have underway, I am optimistic because of the foundation that exists in Maine, and it certainly is a huge contributing factor to Maine having received the State Innovation Model Grant because the foundation laid, especially related to the advancement and investment in primary care and the establishment of patient-centered medical homes. And from the department's perspective, and certainly from Medicaid Maine Care's perspective, the opportunity to build from that foundation, the launching of the health homes, gives me great optimism around what is possible. But I'll be pithy and jump to what gives me, what I'm pessimistic about. And what I'm pessimistic about, though I believe it is absolutely something we can continue to confront, and it is about the challenge of change and the need to evaluate that ever-evolving business model that is going to support the ability to achieve these aspirational goals. And equally important, it is our data orientation and embedding in the day-to-day practices, and I will speak from the department's perspective, the focus on using data to drive decision-making. And within the Department of Health and Human Services, and certainly within Medicaid, we are experiencing our own challenges, some of which play out on the front pages of the paper, around how to develop real-time data information that can best inform decisions, business decisions, policy decisions, and to make us a more effective partner with community providers. Very optimistic about the foundation we've established, concerned about how quickly we can begin to address these challenges around change and data focus.
Great, thank you. Wendy, you're next.
Ladies first. First, let me say it's humbling to sit here because I look in the audience and I see a number of people who could easily switch out and be here in the audience. And I think that is part of what Andy and I were talking about, the secret sauce of what we have thrown the challenge out of being the first state to achieve the triple aim. Many of you know, as soon as the triple aim came out, the Maine Health Access Foundation really embedded those principles into a number of our initiatives, including integrating mental health with primary care, advancing payment reform, and doing a number of other things that are focused on transforming health and healthcare. But one of the things I want to throw out a challenge is I want to throw out the idea that your vision statement I consider a meager goal. To be honest, all right?
Absolutely.
So, if you look at international comparisons, to have Maine be the healthiest state in the nation is sort of a paltry vision. And I think, great, we could aspire to that, but I think we should look beyond that, because I think actually, compared to other countries, we have a long way to go to achieve the quality and health outcomes that AAA really embodies. And I think we need to set our vision higher. One of the things I think is really excellent about the AAA here in Maine is our capacity to work together no matter what our perspectives are. Andy and I and Ron all worked in Washington, and I think one of the wonderful things coming to a state like Maine is in Washington you talk about change and transformation. At the state level, you actually get to do that. And you see people every day, you have to work with them every day, and frankly, in a small state like Maine where we're economically challenged, we do things by dint of necessity. We work together because we must work together. And I think that makes it very powerful for us to be a leader. If Ron deems us the leader in this transformational movement, I think we'll all accept that, because we get in the trench and we try and figure out how to do this together. The thing that I am concerned about is, as we look at the AAA, there are two things that bear further comment. One is the concept of population health, and people have heard me talk about this all the time. You cannot think about managing population health if you are just managing one population, the insured population, the Medicaid population. We are all in this together, friends, and we've got to manage the population, because health reform and transformation will not work, and we cannot bring down the cost of care and improve quality if significant numbers of people in Maine are left out of that equation. It just will not happen. So when we talk about the AAA, we need to talk about population in very broad terms. The other thing that bothers me a little bit about the AAA is I think there's a leg of the stool that's missing, and I've talked about this also. And that's, how do we restore both the dignity and joy of practicing medicine and really being a part of a healthcare experience with patients for providers. We talk about the patient experience of care, but as a physician myself and talking to folks who are nurses, doctors, there's been a transformation in healthcare that has really made providers, I think, lose the joy of what many of us went in to our profession to do, to alleviate suffering, improve health and restore health. and really have a relationship with patients that lead to better outcomes. If we don't focus on that, we can transform a healthcare system and not have people that are ready to step up and be the providers that we want to have in that transformed health system. So I'll leave it at that.
Wendy, that's great. And very fair criticism in terms of the triple aim being limiting. You look at U.S. compared to international on health status. We ranked 37th, I think, in the world in health status. So a long way to go. So Bill, realistic vision, advancing the triple aim, and what are you optimistic about and concerned about?
So I think it is a realistic vision. I'll agree with one thing my colleague to my left said, and disagree with another, which is not unusual to us. First, I think it's realistic, and that I think we have the horsepower in this room to really continue to make a difference around health improvement and around managing populations. The question of whether or not the goal is aspirational enough, and whether or not you believe that we're the 37th ranked in the world, I would like to debate those, but that's a different topic. I think the aspirational goal of being the best in this country is a good goal, and if we could achieve that, I think we'd be all very proud of that. And so I disagree a little bit with Wendy there. Where I do agree with Wendy is if I have a concern in the direction, well, two concerns. One is part of the goal around per capita costs. I think we're focusing on the wrong number. I think we're focusing on a number that inevitably traps us in that it's all about the economic development within this state. If you take healthcare costs, and you compare healthcare costs, cost of education, cost of maintaining our roads, cost of maintaining municipalities, and you divide it into a state GDP number, we continually lose. And that tells you that the denominator is too small. And I believe that if we focus as a state in increasing the denominator, which is economic development, economic throughput, a lot of the issues that we believe we have around healthcare costs, costs of education, costs of road, et cetera, will go away. And so I see more hope in increasing the denominator than adjusting the numerator in those calculations. That's a GDP calculation, an SDP calculation. It's not a per capita calculation. The thing that I absolutely agree with that Wendy said is the issue of managing populations. We can make a mistake here as we get on the road of accountable care organizations and define the populations we serve as those populations who are under the care of an accountable care organization, as opposed to the entire population in the state. So I know as our health system since 97, we have focused on the health of the entire population. As we've gotten into accountable care contracts, though, it's inevitable that you sit and you narrow that focus down and say, what are we doing with this population? What are we doing with these folks that are insured by these folks? And I think that's a mistake, because as we all know, people move from those populations from one to another. And so I agree very strongly with Wendy that we ought to maintain our focus on the health of the entire population and define the entire population that we serve as the 1.3 million people in the state.
Thank you, Bill. So Dan, comments about the vision, how realistic, and
I'm going to pass and get the lane. I'll start by suggesting that the goals and the aspirations in the triple aim very much resonate with us at Anthem Blue Cross and Blue Shield. I think the reason why it resonates is because it addresses what we consider to be kind of the burning platform, and that is affordability. I think both Dr. Wolf and Bill spoke about per capita healthcare expenditures. It's something I spend a lot of time thinking about, but I think there's another aspect to it that we've got to stay focused on, and that is, our per capita spending, and I understand your arguments, Bill, we're 25% above the national average. And when you consider that our median household incomes in this state are 10% below the national average, it's really the combination of the two that create this acute affordability issue that we have to focus on. And so, Anthem, as we've thought about that issue, not just recently, but over the years, we kind of come to the same conclusions that the coalition has come to, that, focusing on the consumer experience, focusing on delivery system transformation, focusing on improved quality, and creating cost efficiencies are the right things to do. Now, I'll share that these aren't futuristic aspirations. You know, we have been looking at this for many, many years. We were early adopters and supporters of the pilot of the patient-centered medical home here in the state. As a larger organization, as part of WellPoint, we piloted the patient-centered medical home concept throughout the country. We know it works. We did this 3 years ago, and we saw that it led to positive results in terms of improving quality and lowering costs. We saw 15% reduction in avoidable ER admissions. We saw 18% reduction in readmissions to the hospital. So we know that model works. We learned that 2 years ago, and from those learnings, we developed a program to implement this statewide. So as we sit here today, you know, these goals are not aspirational. These things are in motion today, and that gives me a lot of optimism. You asked what we're optimistic about. The other thing that I think has really changed over the last few years is collaboration in the state. I've been the president for 6 years, and when I first arrived in Maine, and I've been in the industry for about 15 years, it was very much a tennis match. I'm going to hit this ball as hard as I can back at your side of the court. Let's see if you can hit it back. But that's changed. It has become more of a team sport. Folks realize our backs are against the wall. We have to solve this problem. And the only path forward is if we collaborate. You know, it has to be a win-win proposition for the employers, for patients, for the payers, and for the hospital system. It's the only way it's going to get done. And we're strong proponents of the collaboration. So.
Thank you, Dan. Wayne?
I'm very hopeful. I think that one of the most hopeful things is we already have the answer. We know all the answers. We know what we have to do. It's not trying to figure out what we have to do. It's we have the will to do it. How do we do it? You know, how do we limit the collateral damage? I think that the collateral damage issue is huge because it's mostly the healthcare systems that are really the ones who are going to have to endure the collateral damage because that's just where they are right now. Also, I think that I have a lot of hope because actually of the Maine Health Management Coalition, we were largely unsuccessful at achieving healthcare quality and cost controls at the lab for our employees until we joined the coalition. And it was because of the coalition and the people we met with and the people that we networked with and the data that they provided that we now have a very collaborative approach to the issue at the Jackson Lab and NDI. We meet with our hospitals on a regular basis, the senior hospital leaders on a regular basis. Aetna, our vendor, as well as the healthcare providers and ourselves, meet on a regular basis, talk on a regular basis. I think that that's really important. In Maine, we kind of have human-sized organizations. We're not these great, huge, gigantic things. I mean, we're an employer with 1,500 employees, and in most places that would not be considered a big employer. But here we're a big employer. And so, we have that opportunity to have such close contact with the other players. So I agree that it's we have been collaborative now to a great degree. When we first started on our road to improvement in 2007, we were at each other's throats, the healthcare providers and us. I guess we had to go through that phase where it was in the front pages of the newspaper that we were having issues with the hospitals, local hospitals. We've gotten over that, and we're on a regular first-name basis and see each other all the time. So, and also we have been successful. We have, to a great. One of the reasons I was invited here is that we've been successful. It's not been because of us. It's because of all the partners that we had and we met through the coalition. So as long as we have a healthy and strong coalition, and it continues to thrive in the way it's thrived, I think we have a lot of hope.
Great. Well, those were great opening comments. And what I'd like to do now is move on to the issues of healthcare transformation and then how payment reform, if we can advance it in Maine, can support healthcare transformation. So when we talk about healthcare transformation, we've already, Mary has talked about the medical home. We talked about integrated systems that can manage defined populations to total cost and a higher quality of care. We can talk about transitions of care and chronic care management. We're already starting to see, I think, not only in Maine but around the country, some of these approaches actually, as Dan said, reducing demand for hospital services, for emergency services. But I want to start, and Bill, sort of ask you, because you're the architect of building an integrated delivery system that is, and I'm not just going to say that because you're on the stage with me, but really committed to healthcare transformation. And I want you to talk about what that journey has been like and what are the key components of healthcare transformation for you.
So if I had to break it down into two buckets of issues, it's redesigning the delivery system and redesigning the payment system. And so when it comes to redesigning the delivery system, we're spending an awful lot of our time these days trying to figure out where the most appropriate place to provide care is, to look at the infrastructure that we have built over the years and try to adjust that infrastructure to match the needs that we have going forward. We're spending a lot of time talking about care models, where each specialty of care should a particular service be provided, where should not be provided, where should we have centralized services, where should we have community-based services. And so it's a lot of time being spent on the concept of care models by specialties. When you do that, though, you end up having to make some very difficult decisions about reshaping the delivery system. And I believe we're going to continue as a state to make some significant adjustments in what care is provided in which communities. As we do that, we need the support, we the providers need the support of the business community standing behind those decisions. And we believe we're doing it for the right reasons. We're doing it as members of this coalition to address the AAA, to address the cost of health care. But we need the payers, both the insurers and the payers, being employers standing behind us. We need this coalition being much stronger, talking about the infrastructure costs in the state of Maine and where we need to make adjustments. We have several communities in the state where we have an excess of infrastructure, and we need to make adjustments. And we're not going to be able to do that as providers on our own, and I think there's a need there. Finally, I would say that if we're going to keep the coalition together, which I very much hope we can, we need to be in agreement more on what drives the cost of healthcare in the state of Maine. And I can tell you, coming off a conference a couple of weeks ago that the coalition had, I'm not confident right now that we, the participants in the coalition are in agreement as to what the true cost drivers are in the state of Maine. There is a focus on price, which I think is misdirected, and I think it's going to be divisive when we try to carry that conversation forward in a coalition.
And Bill, we'll get into those issues when we talk about payment reform issues, and I think the type of strategies that we're talking about there. Wendy, I want to turn to you in terms of what for you resonates when you hear healthcare transformation. And again, talk a little bit about concerns for the more vulnerable populations in Maine.
You don't even need to ask. Let me say one thing. I think transformation is a journey that involves a lot more people than we generally have around the table. And first and foremost, it involves patients and their families. And one of the things that I think we are striving mightily to do, not only in the foundation, but I know in everyone's organization, is to try and bring forward those voices, and I think we have to try harder. Let me give you an example. Every program that we fund at the foundation, we usually require that our grantees have the voice of patients and families from our priority population, the uninsured and underserved, involved in the program and providing guidance. One of the applications that we got said, we'll find these patient voices, we'll advertise in the paper, and those individuals will be asked to submit their resumes, and then we will pick who will be the consumers who will guide this transformation. Well, I don't know about you, but the uninsured many times aren't sending out their resumes. And be sitting on patient advisory panels. And it's hard. It's hard to engage, particularly lower income people whose lives are very busy, working maybe 2 jobs, 3 jobs, to really get their input on how they find our healthcare system as it is going through transformation. To be more patient-centered and to really address their needs. And frankly, when we've gone out and asked them, it is not rocket science what they say. They say, I'd love to see the doctor after 5 o'clock. I would love to have someone speak to me in language that I understand. I would love to have someone explain to me why I need a mammogram or a preventive health service. As you said, Dan, these things aren't rocket science. They are easy, but we need to have that voice at the core of how we are transforming healthcare. And then the other thing that we need to do is acknowledge that most of us don't spend our lives sitting in the doctor's office. Most of us spend our lives at home in our communities. And when people leave the hospital or leave the doctor's office, they have to go home and figure out how the heck do I do what they just told me I need to do. If you go to Cherryfield and you go to the Harrington Family Community Health Center, that sits right on Highway 1, and they came to us one time and they said, yeah, we have a bunch of diabetics. We tell them they need to exercise. We don't have any place in the town where people can walk safely because the major road through town is Highway 1. We would like to build a walking track so people have a place to exercise all year round. We promise to keep it plowed so they have a place to go in the winter. And that was pivotal in helping their diabetics begin to exercise and manage their care. So we need to involve people in the community, people who are going to be the ones working with patients and finding out the resources in communities, because they're the essential part of the transformation. We can figure out how to make healthcare better and higher quality, but if we send people out into a world that's not ready to help them do that, then we are going to fail in the long run. So I think we need to broaden our net, and our net needs to be listening to a much more diverse array of individuals.
Great, thank you, Wendy. And you know, your comments remind me of all the times I've been told by individual physicians, and sometimes I can see them walking to a microphone, that, Andy, I did everything right with my patient. I worked them up, gave them the right diagnosis, put them on the right treatment plan, gave them the right medications, and they're out the door. And how do we build a healthcare delivery system where that journey and that conversation with the patient only begins with the 7-minute visit and really supports the patient over time? Which, Dan, relates to the question of disease management. The healthcare plan community sort of, I think, was an early pioneer in care management, following up with patients. Disease management created a whole industry. But now, with Bill's more integrated delivery systems, we're seeing that function move back to where perhaps it's better located with the trusted source, the provider community. Is a maybe a way to reduce costs in the system, to sort of remove the costs with health plans and others who have been paid for disease management for so long, and to move it to the provider, where it might be more effective.
Absolutely. And that is an evolution that we'll see play out over time. I think, but we can't get ahead of ourselves, right? It would be the wrong assumption to assume that every integrated delivery system or every provider has the care management capabilities today to do the kind of work that we do. So we know when a patient is discharged from the hospital, they have a discharge plan, and if they don't adhere to that, it leads to these readmissions and these higher costs that come with the lack of adherence. So we've built processes, we've got nurses and physicians who do that outreach to make sure we've got that engagement with the patient after they leave the hospital. Some systems are well prepared to do that now. Beacon Health has got an NCQA accreditation. That is a major step forward in kind of validating their care management program. So as we see the evolution of these care management programs and the effectiveness of those programs, we will start to delegate those responsibilities to the network. That's why we believe wholeheartedly in the patient-centered medical home concept. And one of the program requirements we have for those physicians in that program is that they develop care management plans for the most risky patients, right? We do some of those things today. We'd like to extend that to the primary care physician's office, have them take on that responsibility. And when that's working well, then we will shut down, for lack of a better word, those kinds of processes on our end, create those administrative efficiencies, and delegate that into the network. We do believe that that's an evolution that will occur over time, but we can't get ahead of ourselves. We've got to make sure that those processes are in place and they're effective.
Yeah. So Mary, let's move on to sort of payment reform, and I think we've teed it up well. They're sort of, they go together. We need a payment system that can support the type of healthcare transformation, primary care infrastructure, population health management, again, care transitions, the things that we do not pay for. And the metaphor that I hear in Maine all the time from providers around the country is sort of a challenge to purchasers and payers is, and I think, Bill, you threw it out there a little bit as well, is that you got to move faster on payment reform. You know, we've got a foot in both canoes, and the old fee-for-service system does not support the care delivery system that we're building. And I even hear from providers, even without payment reform, I'm making these changes in the delivery system because it is the right thing to do. But I would hope that purchasers and payers would catch up. So Mary, I wanted to start with you because Maine Care is about to launch their accountable care communities and shared risk program, and talk a little bit more about that and why you're excited about it and what you're hoping to accomplish with that sort of payment model.
Right, but I want to jump off from what Dan was saying in terms of the transformation of the system and how that is in fact guiding so many of the decisions that Maine Care certainly has made in the last few years. And the foundation of that really is the work that we did around the emergency department collaboration, and it does build off of Dan's comments around supporting providers in the community. And certainly when we talk about our emergency department collaboration with all the hospitals in the state, we're talking about people who have significant utilization of the emergency department and some of the more difficult, higher risk individuals. And these are individuals with significant medical complications, substance abuse issues, mental health issues that have potentially been fired from their physician practices, from their community mental health agencies, and to really reflect on what we need in this state. We need to make sure that we are evaluating those extreme challenges and needs and how we coordinate care. And for us, the work that we've done in the emergency departments, over 1,900 Maine Care members have been case managed through that process. And what it sought to do was to complement where there were case managers and infrastructure, that we would work in collaboration, and to the extent that those case managers, that there was not a robust system, and case managers from the department were core to that team. But a huge component of it, and I think it feeds off of the discussion about it's not rocket science. If we can make something complicated, we will make it complicated. And it's an art form, really. And making it simple and having that person who is in need of better coordinated care at the heart of the decision making is fundamental. And that's why I am so focused on what we've learned from the emergency department collaboration, because it was about case management and it was about really understanding the core needs of that individual. What were their barriers to accessing primary care and better integrated care? And what are the steps that we need to take regarding that individual? And of course, we've had significant success from that emergency department collaboration. And as I said, it's helped to inform more of the framework around the partnerships that we believe is why we were so adamantly opposed, no offense, to managed care, because we wanted to have a direct care coordination partnership with providers, because as we saw providers investing in a team-based approach within their practice, hiring of additional staff, social workers, nurse practitioners, physician's assistants. We wanted to understand, as a payer, how do we embrace and support through the payment model those needs. And we also understand that it's difficult to keep pace with the demands that we have to change the system, to reduce preventable emergency department utilization, to reduce preventable readmissions or admissions, to reduce inappropriate high-cost imaging. As one hospital CEO, I remember Karen recently said, we're doing everything right and we're losing money because our payment reform has not kept pace with those changes. So our investment in health homes, and I will say our primary care practice, Stage A health homes, is just building upon the primary care case management fee. Our movement around behavioral health homes and the payment reform there is more experimental. It is a global payment, and it's difficult, and it is going to be challenging. And from the department's perspective, we've got to learn how to be nimble. And that's not easy for government. So how do we remain open to, our assumption was this, but the reality is this. And so is the rate right? Are we targeting the right population to improve the health of those individuals and providing the right resources? The accountable care communities and our focus on broadening our piloting of experimental payment reform and support of moving main care from a paid-for volume and a transactionally focused payer, claims come in, payments go out, to rewarding quality is experimental. And of course, at the end of the day, I have a federal partner, and they tend to dominate the regulatory structure. And flexibility is not their middle name. And so how we push, but we do have, obviously, the Centers for Medicare and Medicaid innovation. And so continuing to push on how we define innovation and the need to support that innovation and to be open-minded, like any entity or organization, regardless of its government, DHHS, or business, the challenge of getting people around a table and staying open-minded. Instead of the, I built it, it's mine, I'm going to defend it, it's right, it was a policy I designed, to constantly looking at the data and the financial models and the assumptions, and are we driving to the right outcomes? So I am convinced that we can continue to move in this direction. I think there's going to be a great deal of pressure to move quickly, but the more we can keep a clear laser beam focus on the outcomes we expect and the strategies that the research supports will move toward those, help us achieve those outcomes, and the payment that needs to be aligned with those strategies is critical. And we cannot resolve the world's problems all at once. So how we stay focused on what needs to be front and center is critical.
Follow up just quickly with Commissioner's comments, because I think she made a really important point here. And that is when you spoke about the physician who indicated he was doing everything right, yet now he's got a revenue shortfall and some potential insolvency issues. And I think that gets to the heart of, some of the more complex things that we have to address here, which is why I believe in these global risk arrangements, right? And the concept there is that we will preserve revenue inflow while the provider and hospital systems are focused on cost reduction. Because you can shut down your revenue quicker than you can create the cost efficiencies. And that creates an insolvency gap that we just don't want to have to deal with any of our providers or any of our systems. And so these global risk arrangements look to solve that problem, which is why we're an ardent supporter of that model.
And can you talk about where Anthem is going in the whole arena of global risk contracting? I mean, without giving away trade secrets.
I kind of gave it away just now, but I think to have this discussion.
Well, how quickly can we get there? Is sort of to Mary's question.
So there's a spectrum, right, of ways we reimburse the network. On one hand, you've got the fee-for-service, right? That's paying for volume. On the other side of the spectrum, you've got these risk arrangements which pay for value, okay? And for many years, when I first came to Maine, everything was pretty much stacked over to the left. It's a pay for volume. We all understand kind of the shortcomings with that model. It leads to very predictable revenue for physicians and hospitals, but it leads to very unpredictable costs for employers and payers. And so, as a system, we're trying to move these payment methodologies down this continuum so we can get more predictable costs for employers and payers. But the conundrum becomes it's harder for the physicians and the hospitals to anticipate their revenue streams, right? Their costs would outweigh the revenue that they're guaranteed through those models. And so that's why we've got to move down this continuum very delicately. We are making progress. There's a lot of things that have to happen. We talk about the transformation of the delivery system, this transformation of our infrastructure so that we can enable these practices and these integrated systems to be more effective. We have to be better at sharing data. We have to have the data analytics in place. We have to be able to explain to physicians and hospitals where there are gaps in care, where we see opportunities for cost efficiency. We have access to information that at times a physician doesn't have about their own patient. And our ability to integrate that data together to create a holistic view is crucial in terms of moving us down this continuum on payment reform.
So it's very quickly.
A point too, that without Medicare here,
Yes.
and I think that
Yes,
is
thank
a
you.
huge part of what is driving or has the potential to drive change that needs to somehow be at the table. And we talked about that certainly through the state innovation model. How do we have that player as a partner at the table so that the alignment that providers need, that we want to have in driving system transformation is achievable without having one of the largest payers operating in a vacuum or an isolation.
Amen to that. I mean, how many times do we sit around our multi-stakeholder table and say, where's the Medicare representative?
So let's invite them.
Yeah, well, we have invited them. We have. I mean, Medicare is back in Washington, D.C. again. Regional office, but doesn't have the manpower. Anyway, Bill, I'm going to go to you in a second in terms of a response to what payers are doing in payment reform. But Wayne, I wanted to give you the opportunity from an employer's point of view. How important is payment reform to you in the context of where you want to drive things? And are you doing anything in the
First of all, I don't think it's as important as maybe other people see it in other areas. We've been tremendously successful with continuing to have a fee-for-service model and making it work. So it can work. We are right now working to develop a down east, we're calling a down east ACO, where there wasn't really a down east ACO being built, and we very much believe in the concepts of the ACO and risk sharing and all that. We got the hospitals together, Maine Coast Memorial, MDI Hospital, St. Joseph Hospital, Blue Hill Hospital, Eastern Maine, and we're all working together to develop an ACO in the down east area. And we're working with those providers not only as being healthcare providers, but as being employers. So they're wearing two hats in this process. So when we look at the down east ACO as an employer participation, those hospitals are the biggest employers in the area in addition to the Jackson Lab, and we're all working together to put together an ACO that does have risk sharing with the providers. So we're moving in that direction, but I think we can be very successful with maintaining a fee-for-service situation.
So Bill, your perspective, and I guess the global question is whether provider systems are willing to go at risk over time. But then secondly, what has been your experience? You've been a participant in the Medicare Shared Savings Program. You're obviously talking to payers as well about moving towards more global risk sharing. Give us your perspective on where you think things stand and where it's going.
Well, if you believe in the AAA, which we do, then inevitably it takes you to managing the total cost of the care for the population. And so I really do see us going in that direction. As a health system in the first year of the accountable care initiatives, we saw 20% of our volume go into what's called at-risk relationships. Now, each one of those relationships right now is upside gain sharing only. So we are not at risk in any of our relationships. Should we miss a target, we're not obligated to pay back. Should we meet a targeted cost per member month, whatever, or per year, we share in the savings with the payer, including Medicare. So in the Medicare program, you saw in this state two large programs, our Medicare Shared Savings Program, where we beat the Medicare trend factor that was built in. We didn't beat it by the amount that was required to generate a savings. It was 2.3% target. We hit 1.9. And so we expect that in the second and third year under that program, we would eventually share the savings. But that was good news, that we were disappointed we didn't get savings, but I sat back and said we should be celebrating that we beat the trend factor by a significant amount. Saw the same situation occur in the Beacon, as I understand the numbers, the Beacon program up north. Beat the Pioneer targets the first year, did not beat them the second year. So a little bit of evening out over a 2-year period, but again, very much in line with the trend factors that were established by the program. So again, a success story, I think, in the aggregate on the Medicare side. We're seeing similar results on the non-Medicare side as we enter the ACO arrangements with payers. Dan hit it on the head in terms of the challenge that we have, and that as 20%, soon to be 30, 40, 50% of our business goes into at-risk kinds of relationships. The issue is what happens, how do you deal with the decreased utilization, the decreased cost that is sitting embedded on the provider side, and how do you finance the system? And what you have, when you look at the numbers, is a mismatch. And Dan said it very well. You can't take costs out as fast as you can take revenue out. And we're a fixed cost business. 75, 80% of our cost is fixed. And so it takes a longer period of time to take the costs out of the system than it does to take the revenue side out. And we're successful. All of us in this room are successful in the past 3 years of taking the revenue side out. So whether it's the result of efforts that payers have had, providers have had, or the result of a lousy economy, we've seen significant declines in volume over the last 3 years in the state. And it's depressed trend factors across all of the payers. The issue is, though, that we've, as the example that was given, as all of that utilization has disappeared, the economics on the provider side has gotten worse. We took $100 million of expense last year out of our health system. We had declines in utilization across the entire health system. And this year we did not meet budget. We did not meet our budgeted operating margin. Just tells you it's a challenge. We took $100 million out of the cost structure, and that was not enough to offset the revenue declines that occurred, the bad debt increases that occurred over the past 12 to 18 months.
So let's talk about the infrastructure issue. We've teed up this critical issue that demand for fixed cost institutional care is continuing to come down because of transformation and other factors. You have those fixed costs that cannot be supported. Bill, you laid out the challenge that you as a healthcare leader are going to have to make very difficult decisions in terms of right-sizing and downsizing infrastructure that you sit on, and that you need the support of the payer and business community and the coalition when those difficult decisions are made. And in fact, I remember, Bill, when you challenged me on this issue when I first came to me.
Bill challenged you.
Oh, Bill, did he ever? It's hard to believe it. In Ruth Bay, and he said, you know, your employers have been giving me a hard time about my fixed costs and too many hospital beds, and the one time I make a difficult decision, and he goes like this, and I look behind my back, and none of your numbers are there. And I was
I don't know anything about that.
and you know, well, frankly, personally, I think it's a fair issue, and it raises the issue of a broader public conversation about healthcare delivery and infrastructure in the state of Maine, particularly given that we're a very rural community as well.
So the first question are sort of the folks paying the bills, Dan and Wayne and you as well. You know, will you have bills back when those difficult health system decisions are made to reduce those fixed and institutional costs?
Well, I think in our area, we are very much partners with providers. So we see them, like I said, we see them all the time, and I think they know we have their back and we'll be behind them. We have been up until now, and they're fully transparent with us, and I think it's important to have trust. So, you know, if we know they're really hurting, we're not going to push them more, you know, and we're going to say, maybe we need to push less, but work with you more to get this accomplished in 1 year rather than 6 months.
Right.
So I think based on the relationships we have gained with the providers over the last 7 years, that they trust us and we trust them, and we're fully transparent with each other.
And Dan, does this suggest that in terms of particularly ACO contracting, that perhaps payers take on more initial risk in the first couple of years? Again, as the costs come out, new investments need to be made, and providers take on risk more downstream?
Well, a lot of paid innovation does exactly that, right? So we pay per member per month types of fees to primary care physicians. You know, we start that when the program begins, and we don't actually believe that that's going to earn a return for many months down the road. So there's already this initial investment that comes from the payers by way of funding some of the paid innovation. But I want to go back to the infrastructure discussion, because there's an important question here for the state to grapple with. And some of the things that I think about, you know, we have 1.3 million residents in the state, and we have about 39 hospitals. Now, right next door in New Hampshire, they have the same population in 26 hospitals. And so there's a lot of infrastructure that needs to be maintained in this state to deliver care. Now, we're geographically a much bigger state, so that explains some of it. But I would contend if you were to design the ideal infrastructure that we need to serve this state, you know, and then compare that to where we are today, would you see differences? You know, and I would suggest we probably would, which might suggest we don't have the ideal kind of optimized, rational infrastructure that we need to serve the state well. And if we can agree with that, then, you know, it kind of lends itself to, well, how do we get from this ideal state, or from where we are today to this ideal state? And that's where, you know, some kind of a plan, a public plan around the infrastructure that's needed. That would provide, you know, Bill and the other hospital CEOs kind of support, you know, as it relates to some of these difficult conversations that are happening at a community level around what needs to get done to become more efficient. Now, we can't lose sight of, you know, primary care and urgent care and emergency care in every community, but I'm not so sure that we need to have, you know, orthopedic, you know, type surgeries in every community. There's certain things that can be consolidated to gain economies of scale and efficiencies, and that's what a rationalization of the infrastructure would do. So absolutely, I've got Bill's back when it comes to important decisions he's making. He has a bird's eye view around what's cost effective, what's not cost effective, and how he can effectively deliver care to these communities.
So,
Okay, I have to jump
okay,
in.
no, and I want to jump in. No, of course. And Wendy, but let me tee up the sort of question for you.
No matter what you ask, I'm going to talk about it. Okay. Well, in full disclosure, let's go back to a couple of fundamentals. Number one, and we talk about healthcare infrastructure, and we have to talk between systems, payers, providers, and businesses. Guess what? The community's got to be involved in that conversation. I'm a resident of Booth Bay Harbor. Let me tell you the explosion that occurred when the community felt they were left out of the conversation. And guess what? Medicare is the largest payer in most of these smaller infrastructural places that you're talking about. So, as omnipotent as we all think we are sitting here, there's a big payer that drives a lot of utilization and care in smaller rural communities that serve elderly populations. And there's a lot of concern out there about how we continue to meet community needs. Guess what? All of our hospitals in Maine are nonprofits. That means you provide a community benefit because you are a nonprofit entity. And we need to start having honest conversations about what is reasonable in a state the size of Maine to provide a reasonable level of health care in small rural communities. And I agree, I don't think we need to have, as probably as many hospitals as we have, but we need to have people be part of the decision about what's next.
Absolutely, right.
And that needs to be a multi-sectoral conversation, and frankly, not just a business.
I want to clarify, absolutely, the public's view around, how this changes is really important. If I missed that, I apologize.
So Mary, what is the role of the state in creating a venue to have this conversation about the future of healthcare infrastructure in the state? I mean, given that it's such a critically and politically charged issue.
Well, I'm going to set Bill's backside aside.
Okay, all right.
Sorry, I meant that aside.
I'm getting out of control here.
Well, let's just be honest about whether or not we can all sing Kumbaya around some incredibly difficult decisions. And I know that feeling of looking behind and not seeing anyone. So there are some real challenges ahead, and it is difficult to unscramble the egg. So we have a system we've built, and in the department, we feel it acutely because the pressure to produce results isn't out 5 years, it's typically out 6 months, 12 months. And unscrambling the egg when you are trying to drive change in business models that have been built up over 10, 20, 30 decades, and expecting those models to change and to be able to produce results overnight is incredibly difficult. And it's similar to beauty is in the eye of the beholder, efficiency is in the eye of the beholder, economic development is in the eye of the beholder of those rural communities. I guess in terms of the state's role, to the extent that we can help to establish standardized measures around efficiency and expectations around capacity and appropriate access to services. Those are going to be very difficult to define and reach agreement around. But the bigger challenge, and I know I've had this conversation with a variety of providers in Washington County as an example, and it is likely going to be the level of creativity that providers are able to put forward in coming together in organizations that are seeking to address a number of issues that as standalone entities, they are simply not going to be able to affect, nor will the revenue support their ability to achieve those outcomes as independent entities. And when they look in Washington County at substance abuse, behavioral health, access to pharmaceuticals, hospital care, et cetera, I think they are beginning to certainly look at what is a different model around which it will be sustainable to produce these results. So it won't be a one-size-fits-all, but there clearly needs to be more agreement around the way in which we define an efficient, rational system, but a realization of what it's going to take to move in that direction so we don't disrupt and destabilize critical access today, because we've got so many perverse payment structures in place that have led to the models as they exist today.
Well stated. Bill?
I'd like to move back into the conversation on community and involving community, because I think it's a major issue for the folks in this room. Let me first start by saying, stipulating to everybody in this room, that in Booth Bay, on the communications with the community, we screwed up. Okay? So we didn't do it appropriately. In hindsight, we should have done a lot more education and discussion with folks in the Booth Bay Peninsula as we were trying to introduced some significant change for folks in the peninsula. I think we've learned our lesson from that. But sit back for a minute and think about this. If you look at the people that receive care in our provider settings across the state, 60 to 70% of them are either Medicare or Medicaid beneficiaries. Okay? The number of people aren't 60 to 70%, but Medicare and Medicaid beneficiaries consume more than the average. And so if you look at it, you're looking at 60, 70% kind of numbers statewide. And ask yourself, as you involve that part of the community, what incentive do they have in agreeing to have fewer services in any location? For the most part, they are Medicare beneficiaries who have worked all of their lives, and some of us are getting closer and closer to this. I'm buying into this. We've worked all of our lives to fund the program. We're promised a benefit, and we want that benefit. We want everything we got in the past. Anything you take away or change, even at the service level, is a broken promise from their perspective. Medicaid, even less incentive. It's a group of beneficiaries who do not have an incentive to manage the cost of their care. In many respects, they believe they have a promise that's been made to them by our government, federal or state, that we will provide for everyone who's a citizen of this country, equal level of care, et cetera, et cetera. And so one of the large challenges we have here, as the payers, as the employers who pay, et cetera, is we've got a large portion of our community that sits outside the discussion that we typically have here, and they're not interested in reducing services. They're not interested in reducing the sites or the number of places where those services are provided. And it's a challenge for us.
So we've got 15 more minutes to go, and I want to sort of turn it to the audience and get you ready to ask some questions. I'm sure this conversation, stimulating conversation, has brought up a lot of issues in your own mind. As we get some courageous folks in the audience to ask the question, let me tee up the final issue, and that is broader population health improvement. And actually Ron Sims talked about it this morning. And I'm reminded of my public health friend who a dozen years ago came to me and he asked me what I was passionate about, and I said, health status improvement. And he said to me, then why are you working in healthcare? And of course, what he was saying is that healthcare as an influence, as a determinant of health, actually has a pretty small influence. It's debated like 17 up to 20%. And I believe the healthcare transformation that we're talking about, it can be more of an influence, particularly on personal behaviors. But it is the issue of the environment, socioeconomic determinants, the need to build a business climate and job development, which will probably have a much greater influence on health status of our population than anything that we do in healthcare. So the question for the healthcare leaders is, what is your role in connecting to the broader community, to creating those environmental conditions that make the healthier choice easy and conducive. And maybe I'll start the conversation, Wayne, with you. You're an employer. You've built a culture of health within the work site, within those four walls. But, your employees go out into the community. They're influenced by those environmental factors. Does your leadership of your company understand that engagement in building a culture of health at a community level is as important as building one within your four walls?
Yes, we're very active in the community and participate in Acadia Wellness or Health Organization and other organizations in the community that have to do with health. I think that one of the things that we do, for instance, is I think where there's a big win available is making it convenient and not costly for people to engage in wellness activities. So for instance, when we have our biometrics and our health risk assessments done, and really we have a tremendous number of employees and their family members who take, who participate in the biometric screenings and health risk assessments. Though the results of those go to the local hospitals, to the attending physicians of each employee, as well as the case managers at those hospitals. And the high-risk people are identified by those case managers, and the case managers actually come on site at the Jackson Laboratory to see the people who are at high risk. So, and we have a lot of people who participate in that and attend those coaching sessions with those nurses because it's so easy. They're on site. I can just go to the room down the hall, meet with my coach. So I think by making wellness and health convenient for people, to not make it costly, there can be a tremendous amount of participation in that process.
And Bill, I've read your mission statement at Maine Health. It not only talks about serving the patients, but talks about improving health in the communities that you serve. So talk a little bit about sort of what Maine Health is doing more at a community health level.
Let's go to the partnership discussion that you had and to put some numbers to your comments. As a health system, our board has asked us to track our success in improving health, is what our mission statement says. And we did that by adopting a health index, which is a national index, has 19 items in it. And those 19 items are comprised of healthcare outcomes, social and economic determinants of health. And so you look at those numbers, and we initially went in and we identified 6, and now we're up to 7 items that we believe, the determinants that we believe that we could, as providers, directly impact. And so we're focused on those 7. But more importantly, we look at the other 12, whether it's domestic abuse that occurs in the home, whether it's housing issues, whether it's substance abuse issues that are even beyond what we do as providers. When you look at those, the only way we're going to get at those is to partner with others. And so a third of the determinants that we're focused on are ones that we directly control. The other dozen, we're trying to get at through partnering with other organizations around the state. It's not our core competency. Mary runs a very large department that deals with many of those issues. And unfortunately, there are several of those issues not dealt with at all. But we're not going to get there as a state. We're not going to improve the health status of the state without a significant interaction of partnerships around the state. It's not just providers. It's a number of other organizations and individuals that need to work together.
Who would like to be a courageous soul to ask this great panel a question? Anyone? Yes, and please introduce yourself.
My name is Ruth Friedman, and I'm a psychiatrist at Central Maine Medical Center. So I'm responding to Wendy's remark earlier that there's a leg missing from the triple aim. That she was saying that she thinks we really need to look at provider well-being as part of this whole piece. And when I look at what's going on with transformation, there is so much pressure on providers to provide services, often without as many resources as would be helpful. And I just wonder, I'd be interested in hearing more from you, Wendy, or from other people on the panel about how you would address that.
Yeah, I'm happy to, certainly from Medicaid's perspective and the department as a whole through SIM. First and foremost, as we look at Medicaid's obligation in the reimbursement paid to providers, that has been at the forefront as we evaluate the nature of the program in terms of the gaps and have serious concerns about whether or not the resources, as you identified, are appropriately supporting the expectations for the care to be provided. And there are many, many gaps in the Medicaid program in meeting those expectations. Secondly, the nature of initiative overload and the data reporting and the measures to be collected and evaluated is a serious concern, and it goes back to my comment about the need to keep things simple and continue to build from the momentum we create as we continue to make progress around a core set of measures. I am concerned. We know that we've seen practices already that have engaged with us around patient-centered medical homes or around health homes that are getting increasingly frustrated by the expectations that are being layered upon them and the concern about whether or not, from their perspective, it's sustainable. So that has got to be core to the planning and the decision-making around how we align around the core measures and the expectations around this transformation. Because we will lose providers that are critical to the success of this transformation.
Other comments?
Thanks for your comment, Ruth. And, you know, I think one of the things I'm very worried about as a risk for the triple aim is what I call the tension of urgent patients, which one of our staff just wrote about. We are really trying to help providers change the way they both think about and do their practice, and it is messy and it's not terribly easy, and we don't have the structures in place. But I again think that's part of the engagement process, where you really need to ask individuals who are rendering care, what is it that you really need and are lacking to really practice and do the things that you think leads to optimal quality care. I know some organizations are really struggling to do that. I think we need to broaden the conversation, but also have a little more patience and support for the time it takes to do that transformation. I'll give you an instance. The patient-centered medical home, I think, has been a tremendous success here in Maine. I thank Lisa Letourneau for her leadership on that. But it still needs support. It is a transformation that is still happening, and it is not a transformation that is done. So these are issues that need more frank conversation, frankly, because I'm a little worried the provider voice is not as robust as it needs to be.
Bill, comment?
Just a comment on the stress on providers. I think whether it's a primary care practice, which is totally overloaded in what we're asking you to do these days, or a hospital, we've got to start focusing down. It's you know, one count was each of our hospitals reports 396 different quality measures to a number of different organizations. I heard someone say 600 the other day. I'm not going back to comment, but it's a big number either way. Where it's out of control, and that's a level of stress that gets put on providers. Yeah, take Maine Medical Center. I think we could all agree, reasonably good provider, pretty good quality. You know, in a 3, 4, 5-week period, including the one coming up, you'll hear Maine Medical Center described as top 100 in the country in some quality measures, and you'll hear them described as getting a D on a report card. And don't use Maine Medical Center, use every hospital in the state of Maine. It happens in tiering programs that we all have. Some hospitals do well in some settings, don't do well in other settings. All different measures being applied, and it can't all be true. And so that's part of the stress that I think we're on providers these days, is we're not focused.
I've been given the high sign, is that right, Nancy, that we've got to cut this conversation off? Will you please join me in thanking Bill Kieran, Wendy Brooks,